Topic for today is leprosy. It's a very important topic for your upcoming PG entrance examinations, and all the important points which have been asked or have the potential to get asked are included in this PDF. So let's begin. Leprosy, also known as Hansen's disease, is a chronic granulomatous infectious disease, and it mainly affects your skin and nerves. So the etiology of it will be an infection, which is a bacterial infection which we all know as Mycobacterium leprae. This Mycobacterium leprae, like Mycobacterium tuberculosis, is also acid fast, although it is lesser acid fast as compared to that. Another mycobacterium which we don't know is Mycobacterium lepromatosis, because it causes leprosy in Mexico. There's a diffuse form of leprosy that occurs in Mexico which is known as lucio leprosy. That is the one which is caused by this lepromatosis. The pathogenesis, the one main compound that's important here is your PGL1, which is your phenolic glycolipid, which is involved in this pathogenesis. The transmission, as we all know, is through the inhalational route, but that's a major form of transmission. The other minor form of transmission is your skin to skin contact. So it can transmit from skin to skin contact. That's a minor route of transmission. Now for culture, we know that there is no artificial culture media that's available for leprosy, so that's why we use these two organisms to culture it. The first one is your foot pad of mouse. As you can see, the site of M. leprae where this is cultivated is your foot pad of mouse, and the another one is your 9-banded armadillo. This is your 9-banded armadillo. The targets for it, as I've already told you, are skin and nerves. Within the skin, it's the macrophages, and within the nerves it's your Schwann cells. So that's why there's a loss of sensation being involved in leprosy, because the Schwann cells get affected. What's the first modality to get lost is your sensory modality, and within this sensory modality it's your temperature which gets lost first. That is a hot, within the temperature it's your hot and cold discrimination which gets lost first. Now we come to the Ridley-Jopley classification, which classifies the leprosy from tuberculoid pole to the lepromatous pole with respect to your cell mediated immunity. So the hallmark of it is your cell mediated immunity, on the basis of which it is classified, and as we go from the TT pole to the LL pole, the cell mediated immunity starts decreasing. So a person who has got a good immunity will develop a TT type of leprosy as compared to that of a person who has developed a lepromatous type of leprosy, must be having a very bad cell mediated immunity or a poor cell mediated immunity. Now in TT type of variant, I'll tell you the main characteristic points, how to differentiate between all these type. So the first is your tuberculoid type. The lesion here is very a small lesion, and the site is also fixed. The site is also very lesser in part of the site is involved, and there are usually up till 3 skin lesions which are identified, and nerves involved are also very less. So here number of lesions are less, and the nerves involved are also lesser. So the hallmark of this lesion is an annular plaque with central scarring. As you can see in this diagram, in this image, with central clearing, sorry, not scarring, with central clearing. Central scarring is there in lupus vulgaris, which is a form of tuberculosis, cutaneous TB. So annular plaque with central clearing, that's a hallmark of it. You can see here in this image that the annular plaque is here and the center is quite cleared. So on a side profile, it has also been described as a saucer right way up, like the cup saucer which we place it on table. How will it be on the side profile? It will be like the outward edges are sloping upwards. So that's what happens here. The annular plaque which is on the periphery, it has its edges as sloping upwards. So this is also known as your saucer right way up. In contrast to it, there is an inverted saucer appearance which occurs in a borderline type of leprosy. What is this inverted saucer appearance? It is just the opposite. As you keep the saucer inverted, what will it look like? It will look like this. But because central flaring is a hallmark of leprosy, so here the center will show a punched out appearance, but the outer edges which will look like same. So the inverted saucer has been used to describe the outer edges, that is here the outer edges are sloping downwards. Okay, so that's the difference between TT and BB. So it is known as inverted saucer appearance, and the center is punched out appearance, which is known as your Swiss cheese appearance. And there are multiple lesions which are present in the borderline type of leprosy, which has also been described as a geographical map like lesions. And now we come to the BT pole, which is a borderline tuberculoid pole. This borderline is just a transition between the TT pole to the LL pole, and as we go from TT to LL, the cell mediated immunity decreases. So here what happens, like the cell mediated immunity is slightly poorer as compared to that of the TT variant in the BT variant. So here the lesions are known as your satellite lesions. Satellite lesions means that these are smaller peripheral lesions, as you can see in this image, these smaller peripheral lesions which are present around the main lesion. Here you can see the main lesion, this is the main lesion, and this is your satellite lesion. So here there are both ill-defined and well-defined lesions. Like in the TT pole, you'll see only and only well-defined lesions, like this lesion is properly well-defined. Here in BT, you'll see both ill-defined and well-defined lesions. This is an ill-defined lesion, and on the periphery of it is lies the satellite lesion, which is quite well-defined. So this is a hallmark of the BT type of variant. Now we come to this B we already told you, and BL is something which is tending to be bilaterally symmetrical. Okay, so here what happens is, like, the number of lesions starts increasing, so you can't differentiate whether it's just unilateral more or it's bilateral. So it's like tending to become bilaterally symmetrical. This is the hallmark of borderline lepromatous kind of leprosy. As we go to the lepromatous type of leprosy, there are a huge number of lesions which you can't distinguish as unilateral. It's just like bilaterally symmetrical. And not only just there are skin lesions, in the later phases what happens, like there are many deformities that starts developing, like saddle nose deformity. Other than that one deformity you can see here in the late phase is like, this is known as leonine facies. Leonine facies means lion like facies. So much of bacteria is there, and so much of granuloma is being formed, while in lepromatous kind of leprosy there are lesser number of granuloma being formed because the cell mediated immunity is so less that it can't contain the bacteria, so lesser number of granuloma are being formed. But foamy macrophages are present on pathology, on biopsy you can see that. So here leonine facies is characteristic. Other than that, these infiltrative plaques which are present, these are used to take sample for your slit skin smear, not only from the ear lobules, from the chin, from the forehead, or from the buttocks and thighs. You can take this slit skin smear samples and then find out how many bacteria are there, and then classify them into two types, which is paucibacillary and multibacillary, which we'll read later. Now we come to another type of leprosy, which is your indeterminate type of leprosy. Indeterminate means something is not defined. What is not defined? It's your cell mediated immunity. So in children, because they're not being exposed to so much of infection, their cell mediated immunity to this particular bacteria is not being defined. So what happens is, like, this is a very milder form of leprosy where only just hypopigmented macules are present on the face, and these are ill defined. As you can see, not only the face is not specific, but yes, face is involved. So how will you differentiate on seeing this lesion? It's very close to the appearance of pityriasis alba type of lesion. So how will you able to differentiate between these two is the presence of scaling. Like if the scaling is present, it's more in favor of pityriasis alba, but if the scaling is absent, then it is more in favor of your indeterminate leprosy. Now we come to the lepra reaction. Lepra reaction is once the patient has initiated the treatment, then during the course of the treatment there might happen these kind of reactions. So these are totally normal reactions which the patient have, and so you need to counsel the patient that during the course of the treatment you might have these kind of lesions. So you need not worry, you need not stop the medication, so you have to continue the medications. So if the question is asked like this, like these lepra reaction have been described, and you are asked whether to stop this the stop the treatment, that is possibacillary treatment or multibacillary treatment, you will say no. What because these are just like body is getting its immunity being formed again. So these lepra reaction occurs with treatment. These are two types mainly, type 1 and type 2 lepra reaction. The difference between these two is that in type 1 lepra reaction, what happens here is that the pre-existing lesions start becoming much more prominent. So here, as you can see, there might be earlier a face lesion of leprosy, but after the treatment it became like this red and erythematous and very tender kind of a lesion. So here what happens, like pre-existing lesions becomes erythematous and tender, as compared to that in type 2 type of leprosy, where there are new lesions being formed, and these new lesions are usually nodules. So new nodular lesions are being formed. That's why it's also known as ENL, which is erythema nodosum leprosum. That is, new lesions are usually the nodules, that is, they are present at a newer site, not where the original lesion was present. Other than that, there are no systemic features like fever or arthralgia which is present in type 1. But yes, there are fever and arthralgia systemic features being present here in type 2 type of lepra reaction. One more thing that I want to tell you is the type 1 lepra reaction is a type 4 type of hypersensitivity, and type 2 is a type 3 type of hypersensitivity, making the sum equal to 5. So there is a rule of 5, which is actually not a rule but a mnemonic to learn these. The type 1 is type 4 and type 2 is type 3 kind of hypersensitivity reaction. So type 3 type of hypersensitivity means immune complex mediated. So these immune complex, they get deposited in various parts of the body, and that's why these nodular lesions are being formed. What's the treatment? The treatment of the type 1 is just giving NSAIDs as the first line, but if it's not resolving, then you can go for oral corticosteroids. Whereas in this type 2 kind of lepra reaction, the treatment is oral corticosteroids. Then we come to another phenomenon, which is Lucio phenomenon, which is also a type of lepra reaction. It happens in Lucio leprosy, which I already told you, which occurs in Mexico, caused by Mycobacterium lepromatosis. Here, these lesions are quite dangerous to look at first, because here what happens is like the blood vessels are involved. So here thrombosis and vasculitis are characteristic, and what you can see on the skin are these necrotic lesions. These are necrotic lesions with an irregular necrotic lesions with irregular edges, as you can see in this picture. Now we come to the diagnosis of leprosy. Like, all the three criteria have to be met to diagnose it as a leprosy. And what are these? These are skin involvement. Skin involvement in the form of hypopigmented patches along with the loss of sensation. That means that the loss of sensation presence is important. Secondly, the nerve involvement. Nerve involvement is in the form of thickening plus loss of sensation plus minus tenderness. Tenderness might be present or might not be present. You can still make the diagnosis. Other than that, there is slit skin smear, and I've already told you it's taken from earlobes, forehead, chin, or from buttocks or from thighs. What is it frames its results as minus and plus, that is negative and positive. But the minus doesn't mean that there is absence of bacteria. There is just that there are fewer number of bacteria, and there is a set criteria below which it is considered to be negative. So if there are few bacteria, we classify it as possibacillary. If there are many bacteria, we classify it as multibacillary. So that's how the treatment has been framed. In possibacillary, the skin lesions are just 1 to 5. In multibacillary, they are more than equal to 6. The nerve involvement is 0 to 1 here in possibacillary, and more than 1 it is in multibacillary. And slit smear will turn out to be negative. Here it will be positive. So how is the treatment different? The treatment is different in terms of duration, because the kit that is being provided now, earlier it was green kit for possibacillary and maroon kit for multibacillary, but now there is a single kit which is a maroon kit, just that the duration is different. Here in possibacillary you give it for 6 months, here in multibacillary you give it for 12 months. 3 drugs are there, R, D, C, that is rifampicin, dapsone and clofazimine. Rifampicin is given at a dose of 600 mg. This is an adult dose. Okay, so adult के लिए maroon kit, for children it's a brown kit. 600 mg OAMS. Dapsone is 100 mg OD. OAMS is once a month supervised. Okay, so you will have to give it like starting dose as rifampicin, one tablet, and you will give it in front of the patient. And then you ask the patient to take the kit along with him and take it for the entire duration. Now the dapsone is 100 mg OD, and clofazimine, if you want to learn it, you just half the doses of both rifampicin. So this becomes 300 mg OAMS plus this half is 50 mg OD. So in the presence of the doctor, you'll give rifampicin and clofazimine. Rifampicin dose 600 mg and 300 mg OMS, and rest all the tablets have to be taken by the patient throughout the duration. In children, it's your brown kit. Along with that, the dose is also different. Rifampicin, dapsone and clofazimine. For rifampicin, it's a lower dose of 450 mg OAMS. It's a half in dapsone, which is 50 mg OD, and it's clofazimine, it's slightly half, you can say it as 150 mg OAMS, but this 50 mg OD is just half, that is 50 mg on alternate days. Okay, so one thing is important here, that's a side effect. So rifampicin, why is important? Because you need to counsel the patient that these things might occur during the course of the treatment, so these are completely normal, don't stop the treatment. Okay, so rifampicin, here is the urine discoloration of reddish orange urine discoloration. For dapsone, it is agranulocytosis. So you need to monitor this continuously. And for clofazimine, it's your ichthyosis and pigmentation. So these could be asked in the exam, and these are also important to counsel the patient. Now we come to the chemoprophylaxis of the patient. That means you are giving some drugs for the prophylaxis, like the patient is there and there is someone who is in contact with the patient, so you can then only prevent the leprosy from having. So for these three people: one, if the age group is more than 2 years, or if the contact with the patient is more than 20 hours per week. Okay, or if you are living with the patient for about more than 6 months, then you need to take this chemoprophylaxis, and it's just that there is a single dose rifampicin for adults. For children, it's also rifampicin, although the dose is different. Single dose rifampicin, which is 600 mg. So this is the dose, it's in adults. For children, it's different, and you need not know that. Okay, so for now we come to this NLEP program by the government. This NLEP stands for National Leprosy, whether it's elimination or eradication is important. It is National Leprosy Eradication Program, because leprosy is already eliminated from India. When is it eliminated? Elimination has happened on 31st December 2005. India was declared leprosy eliminated. Okay, so eliminated means that there is no local transmission. So from India, you can say that this leprosy has ended, because the incidence, not the incidence but the prevalence, has been less than 1 per 10,000 population. It's not that there is zero leprosy cases, but yes, they have reduced to less than 1 per 10,000 population. So that's why it has been declared eliminated. But eradication means when there is no global transmission. If globally the disease is present, then we can't say it as eradicated. This NLEP program was launched in the year 1983, and this is the symbol of this program. What does it denote? There is a lotus. Lotus denotes beauty and purity. That is, these leprosy persons are still pure. There is an affected thumb, which denotes that leprosy patients are useful member of the society. And there is a ray of hope, which is denoted by this rising sun. So this rising sun denotes hope and optimism. Okay, so these are some important points about leprosy. Hope this helps you in your PG entrance examinations. Thank you.